Hi, my name is Connie Klanis and you're watching the video Duane's Retraction Syndrome Management. In this video, we will be discussing the management options, both surgical and non-surgical, for patients who are diagnosed with Duane syndrome. Let's commence with a non-surgical management. The general principle is that if your patient has a controlled deviation in primary position or is straight in primary position, these patients are best left untreated. And what I mean by untreated is do not surgically intervene. If anything, give them conservative measures to deal with any diplopia that they may be experiencing or due to the limited eye movements that they have. But surgery is left to patients with certain features that we'll talk about in a moment. These patients who are straight in primary position have an area of BSV that includes primary position and generally function fairly well or develop coping mechanisms to function fairly well. So the best options for a patient with a Duane's syndrome who's not going to have surgery is utilising an abnormal head posture or moving their head rather than their eyes. These are also going to be utilised for patients who do have surgery. Post-operatively, they will still require some other measures to assist them if they have restricted ocular movements and diplopia in various positions of gaze. You generally don't need to teach patients how to utilise an abnormal head posture. Most patients with Duane syndrome have actually adapted to the condition and have learned how to position their head in order to centralise their area of BSV and in order to improve the cosmesis. By now you would have actually seen a video of a young woman who is utilising an abnormal head posture to centralise her area of BSV and for the purposes of improving cosmesis. So when do we consider surgically intervening? If the patient has an uncosmetic strabismus in primary position, if the abnormal head posture that the patient is using is uncomfortable or very significant, and when we see globe retraction or upshoots or downshoots that are relatively significant and again are a cosmetic issue, operations can be performed to assist the patient in these instances. So in terms of the aim of surgical intervention, well, if it's for the purposes of the abnormal head posture, we're trying to relieve or reduce the abnormal head posture. And we're also trying to centralise the area of BSV so that there isn't that need for that abnormal head posture. In terms of where there's a deviation in primary position, we're going to try and correct that manifest deviation in primary position. And where there's globe retraction or upshoots, downshoots, obviously that's going to be an aim to try and reduce those. Now, when operating on these patients, it's very important that the patient is made to understand that surgical intervention is unlikely to improve the horizontal ocular movements because the etiology, the cause, is a miswiring of the third nerve. And so it's very difficult for the surgeons to overcome this through surgical intervention. So this is important that the patient is explained this because otherwise they will enter surgery with unrealistic expectations and be disappointed. The aim of surgery is to centralise that area of BSV and avoid retraction of the globe or upshoots, downshoots, depending on the patient's situation. It's not necessarily to improve abduction, for instance. It's very difficult to achieve this. So we'll discuss some general principles in relation to the management or surgical management of patients with Duane syndrome and some options that are available to surgeons. Again, this is not going to be an exhaustive list of the surgical options. There are others that are not included in this video presentation, but I'll go over some of the more common procedures discussed in textbooks and performed by surgeons. If we're trying to improve the cosmesis of the strabismus in primary position, then we consider whether we have an ESO or EXO, and then weakening procedures are performed accordingly. So where a patient has an esotropia, and this patient will generally have a type 1 Duane's retraction syndrome, then the medial rectus is recessed. And remember, the type 1 generally has a normally functioning medial rectus. For larger angles, you can do a bilateral medial rectus recession. Where there's an exotropia, and in this instance it tends to be the patient with a type 2 Duane's retraction syndrome, then we're looking at recessing or weakening the lateral rectus. And again, if it's a larger angle, you can go to the contralateral eye and recess the lateral rectus of the other eye. Now, the general principle for Duane's retraction syndrome is to only utilise recession procedures or weakening procedures. Resections tend to increase globe retraction, so it's avoided in Duane's retraction syndrome, which is why all you've seen I've mentioned so far is recessing a muscle rather than resecting it. Another option is to transpose the vertical muscles or the vertical rectus muscles to the lateral rectus. This is for patients with a type 1 Duane's retraction syndrome where abduction is limited or significantly limited. The issue or the concern with doing this procedure is that you could create a worsening of the co-contraction. So as the patient attempts to adduct, now that you have a more functioning lateral rectus, what could happen is greater amounts of co-contraction, therefore greater amounts of retraction of the globe and narrowing of the palpable fissures. Patients who you feel or the surgeon feels are at risk of having a worsening of the co-contraction often will also undergo a large lateral rectus recession. In this instance, what we're trying to do is create an abduction effect that's primarily being driven by the vertical transposition rather than the lateral rectus itself. Let's have a look at a patient who's had surgical intervention for their Duane's retraction syndrome. Here we have a young child who has a bilateral Duane syndrome, and it's a type 1 DRS, and it's type 1 for both the right and left eye. In primary position, we can see that the patient has an esotropia, and this measures at 35 diopters. They also have an AV pattern, which I can't show you here because I don't have up gaze or down gaze, but we can see that they're utilising a chin-up position and the eyes are straight when the eyes are down with this chin up. Let's now have a look at the Duane's retraction syndrome. Let's start off with the right eye. So when the right eye is looking into right gaze, we can see limited abduction. And when they're looking into left gaze, we see that there's relatively normal adduction there. If we move over to the left eye, in right gaze, there's almost full adduction there, maybe a slight under. And then there is significant limitation of abduction in left gaze. So for both the right and left eye, we have a type 1 Duane's retraction syndrome. This patient then had an operation and they've actually had the medial recti recessed, and you can just see from the images below that there's some redness here on the medial aspect of the right eye and some redness here on the medial aspect of the left eye where there's been an operation. So we've had bimedial rectus recessions, and the surgeons actually moved those medial recti up to assist with the A pattern, given the significant head posture there. Now, the reason for surgical intervention in this instance would have been, 1, because of the abnormal head posture, and 2, because of the significant esotropia in primary position. So what do we think about the post-op outcome? In primary position, the patient looks really good. So they look straight. They may not actually be straight. You need a cover test and to have a look at binocular functions here. But cosmetically, they look really good. If we compare it to pre-op, where we've got the 35 diopter ET, post-operatively, this patient looks relatively straight. And if we look at the abnormal head posture, the patient now is not utilising the abnormal head posture and seems to be relatively straight, looking in primary position there. Let's now have a look at the ocular movements. If we take a look at the patient over here to the right eye is still limited in abduction, but if we look over here, there's more limitation of adduction here. So here we had some adduction deficit, and now we have more adduction deficit. Well, you recessed the medial rectus, or the surgeons recessed the medial rectus, so this was an expected outcome. If we have a look over into left gaze, we've got limited abduction as we did before, and we also have limited adduction, which is new, again, from the recession of the medial rectus. Now, I don't think this child is in the same position in this particular photograph as they are here. So I think the eyes could get a little bit further out and further in, but there's certainly more limited adduction of the right eye as compared to preoperatively. So what's been achieved here? The purpose of surgical intervention was to improve the cosmesis in primary position and to improve the abnormal head posture. And these two things were achieved. However, what we didn't do is improve the ocular movements or the limitations of the ocular movements. They actually are worse to some extent now in adduction. So this is why it's really important to explain to your patients what the purpose of surgery is and to explain to them the impact on the limited eye movements, which is, it's not going to improve. It's unlikely to improve, and if anything, in some instances, some limitations may be slightly worse. And this is, again, the other reason as to why it's preferred that these patients be left alone if they don't have the indicators for surgical intervention. So despite the fact that, yes, they have limited eye movements, yes, they might have globe retraction or some globe retraction and some narrowing of the palpebral fissures, if cosmetically they look good, if they're able to adapt with a cosmetically acceptable abnormal head posture, etc., best to leave these patients alone. Okay, what can we do for patients who want to address the globe retraction on adduction or the up and down shoots on adduction? Let's start off with the globe retraction. In this instance, the best option is to recess the lateral rectus. Remember that retraction of the globe and the narrowing of the palpebral fissures is happening because of the co-contraction of the medial rectus and the lateral rectus. So if you weaken that lateral rectus, the co-contraction will be weakened, and therefore you should see an improvement in the retraction of the globe. In terms of upshoots and downshoots, what you're trying to do is prevent globe slippage and the reasons for that upshoot and downshoot. So one thing you can do is weaken that lateral rectus, and another thing is to do a Y split. So here, to the right here, we have what looks like a Y split. You take the lateral rectus and you split it so it doesn't slip on the globe as easily. In this instance, you could also add a recession of the lateral rectus, so recess it and then split it. Another option is to do a posterior fixation suture of the lateral rectus, which is essentially a Farden procedure, and this has been found to also assist in improving upshoots and downshoots. The Y split is probably one of the more popular procedures for up and down shoots, particularly if you think it is globe slippage that's causing the issue. And finally, I've included here a table from a textbook that outlines some of the golden rules that surgeons utilise in managing a patient with Duane's retraction syndrome. And it mentions those that we've discussed so far, such as avoid resections, and recessions of the rectus muscles are the most predictable and best option in patients with Duane's retraction syndrome. Okay, so in conclusion, where possible, leave the patient untreated rather than going into surgical intervention for patients with the Duane's retraction syndrome. Prescribe conservative management where possible, and this will usually include an abnormal head posture or moving their head rather than their eyes. Again, most patients don't actually need to be taught this. They will generally learn to do this on their own and adapt to centralise their area of BSV. In terms of surgery, remember the indicators for surgery, as we want to generally leave these patients untreated. So only treat where required, where you have a significant deviation in primary position, where you've got large retraction of the globe, where you've got significant retraction of the globe, or large upshoot downshoots, or where you've got significant abnormal head postures. Okay, so where you're doing surgery, focus on recessions, weakening procedures. Do not aim for strengthening procedures. And look at other options such as transposition of the vertical muscles to the lateral rectus, or look at Y splits of the lateral rectus, or Farden operations are also some options that are utilised in Duane's retraction syndrome. But overall, leave these patients untreated where you can. Okay, that brings us to the conclusion of this video. Thank you for watching.